everybody. It's my great pleasure to be introducing Dr. Harley to you today. Dr. Harley did his PhD at McGill University in educational psychology, and then did a postdoc at the University of Montreal in the Department of Computer Science, and then went to Alberta for his sins, where he was an assistant professor in educational psychology and technology until 2019. Dr. LaChapelle and I had the great fortune to recruit Dr. Harley then, and he joined the Department of Surgery as a scientist at the RI and an assistant tenure track professor. He set up the Simulation, Effect, Innovation, Learning and Sales Lab, and he's become the Director of Research at the Steinberg Center for Simulation and Innovation and Learning. His overall research program is to support the current and future well-being of clinical performance and healthcare trainees through innovative educational interventions. He's got over 50 peer-reviewed publications, serves on editorial boards, has over $1 million in funding, and interacts often and very eloquently with the media. The title of the talk today is Emotions in Health Professions Education, Different Data Channels, How to Use Them, and Why Data on Feelings is Critical for Supporting Learning and Psychological Wellbeing. Dr. Harley, welcome.
Thank you very much, Dr. Bartlett. I was asked initially by Misha if I wanted to give a talk on some of our work that we've been doing with artificial intelligence, particularly a scoping review. I'm very pleased that as of yesterday, our work was published or was accepted for publication. So that will be coming out soon in the American Journal of Surgery, and also Advances in Surgical Innovation, an editorial where our group put together a new definition of artificial intelligence for surgical education in particular, which we're really excited to share with people. And both of those publications were led by one of my postdocs, Dr. Biljic. I won't be talking about artificial intelligence today, but I'd be very happy to talk about, if anyone has any questions, or maybe this is me trying to plant the seeds of questions in you, about the intersection between artificial intelligence, learning and emotion, as that's an area that I'm very interested in. I'll talk just a little bit about it today in terms of some of the technologies we can use for it. But I think that people are in different places of awareness with regards to how we can use AI to support emotions in educational interactions. Anyway, without further ado, I'm going to shrink the screen so I won't be able to see your face anymore, Jake. I'm sorry, but I'll let you just stop me if there's any questions, and I really do welcome questions as we go. Since I can't see the time on this view, I'm going to try to run something, so a stopwatch, so that I've got a bit of a sense of how we're doing. So thanks again for the invitation. Roughly what we're going to talk about today, or what I'm going to talk about, and I hope you have questions about, are emotions, and kind of what the two big pillars, I would say, where emotions are relevant when we think about healthcare training, is the importance of practicing learning to cope with our emotions, and in particular with learning how to cope with emotions in more authentic situations and where stress is something that's more tangible, something that we can feel. And again, simulations can do a great job of helping us to get experience in that regard. We'll also talk about the role of emotions in training, and the fact that educational psychology for a little over a decade now has been highlighting the associations that emotions have with learning. And I'll talk about that too. I'll talk about also some different ways that we can look at measuring emotions. In my lab, we're especially excited with using psychophysiological measures, which we're even more excited to be able to start doing again very soon with where we are right now in the pandemic. And I'll talk a little bit, if there's time, about some of the ideas in terms of what's next. And I'll weave into this, some of the research that I've done or am doing with some of the great people that I'm fortunate to work with. So we know, thinking of this first point, the importance of practicing coping with emotions, this really shouldn't be a surprise. There's been lots of articles in the media talking about the challenges that people have faced with regards to, burnout and other types of forms of psychological distress, sometimes having very real and tragic consequences, not only for patients, but for healthcare providers as well. And this has really brought home the need for essentially some kind of well-being curriculum and bringing this into healthcare professional education, which is part of my diabolical research agenda, I suppose. I've had the chance to speak quite a bit about emotions and coping mechanisms and emotion regulation in media, as well as through some special talks through different associations ranging from industry such as Bayer Canada to the Canadian Association of, or the Royal College of Obstetrics and Gynecology, and some other groups as well. I'll be giving a talk in February for the Jewish General Hospital as well. So this is really something that has been and remains front and center on people's minds. We know basically that there's a high stress and psychological distress. These two issues were already something that people were aware of in the literature well before COVID. Things only got worse essentially with COVID. This has had kind of a spout of consequences in different directions, which we'll talk about in a moment. And we certainly need to do more than download mental health responsibilities solely to healthcare workers and trainees. Some of my colleagues and I saw Dr. Friedon as well. So we've had the chance to conduct, I think this was one of the first studies, or maybe the first study that was done in Canada. And this was done in the Montreal or the McGill University Health Center. And our findings effectively confirmed what we were seeing all over the world with regards to what was going on in China, and then in European countries such as Italy. We were seeing things like the fact that about 50% of nurses who were surveyed as part of our study said that they had the intention to quit, and it was around 20 to 25% of physicians. And unfortunately, these numbers really did herald problems with regards to healthcare professional retention. As we saw, these numbers were from, I think, a summer and a half ago in 2020, I think. We saw, again, a lot of problems with regards to healthcare retention around that time, but especially a few months later. On the positive side, we did find evidence that adaptive coping strategies really did make a difference in helping healthcare professionals manage and deal with these elevated levels of stress and distress that they were experiencing. One of the things that informed our thinking with regards to approaching our study, and I think informs our thinking of how we think about psychological well-being in healthcare, is this extended model of stress, stressors, stress, and psychological distress, which we're now at minor revisions with after well, actually not that long, just a lot of waiting for feedback, but that's fine. That's how all journals are right now. So we're hoping that this is out soon. But basically what this model we think is helpful in illustrating is that there's different opportunities for not only individuals, but for those around them, as well as for the healthcare institutions and systems that we find ourselves in, to provide, to help moderate some of these challenges. So for example, we have a stressor, so a lack of resources, whether that's PPI or time or staff. This leads, as we know, to greater levels of stress. Stress can be kind of conceptualized in different ways, and this is where this has an overlap with our topic on emotions. So I'll go and formally define emotions a little bit later, but we think of stress colloquially often as a kind of something that's negative and unpleasant to experience, and also something that heightens our activation. It kind of can fill us with nervous or unpleasant energy. Feeling that way for too long can lead to psychological distress at times at a clinical level, such as anxiety, depression, burnout, or compassion fatigue. And so one of the ways that we've extended this model was talking about, how providing more detail in terms of some of the other factors that go on, including some of the outcomes, and painting that connection between them. And so psychological distress, as we know, and as the literature has illustrated, can lead to adverse patient outcomes, healthcare professional outcomes as well, suicides, absences, harassment, as well as adverse institutional outcomes, including people leaving, quitting, etc. Which in turn, you can't see, there's no laser pointer, but in turn this goes, and then these things basically become stressors. Having an unsuccessful patient outcome, that's a stressor that can again lead to more stress. Having, losing colleagues, either to people quitting or people going on health leave, that's once again another form of stress. So this forms a kind of what we can call a vicious cycle. And that's where it's especially important to know and to be aware of resources that we can use in order to help ourselves and help others feel better. And so one of those is being mindful of sources of support, so friends, training options. There are a variety of other things. These are just some examples. These can moderate the relationship between stressors and stress. So in other words, that can help to lessen that impact between stressors and stress. So can coping strategies, but only if the coping strategies that are used are adaptive. So if the solution is to start getting drunk to deal with stress, that's not going to help, unfortunately. On the other hand, engaging in adaptive strategies like positive reframing, so in other words, changing how we're thinking about something, that can help, and that can mitigate our risk for psychological distress. And indeed, one of our findings, and our most positive one, was indeed that adaptive coping really did support healthcare professionals in mitigating the influence of stress. We found, with regards to support, one of our other interesting findings was this effect of people were not always aware of some of the counseling services, for example, that were available to them. But of those who were aware and of those who said it was useful, a very small percentage of people actually access those services themselves. So there seems to also be some differences too between whether people might think something could potentially be helpful, but whether they're willing to actually access them themselves. This potentially points to some issues that we're well aware of with regards to kind of some of the culture of medicine, with regards to some reticence with regards to help seeking. But this is important for us to know too with support from a systems point of view. It's not enough to simply make services and make counseling available. There needs to be, some strategic communication going in to help encourage people to take advantage of these services if they're of need. Finally, we talked about the importance of context, and this is a very high-level overview of this model. And we noted, for example, that these relationships, this was really a COVID-specific modeling. So all our kind of bright, bold, signs are the relationships that we observed in the literature with regards to these different model components. But there's also some light, faint gray ones that illustrate that things could go in different ways. So context, for example, if we're thinking about COVID, this is a source of many stressors. So this was not so good. But in other cases, context can be protective. And it could again, remove or retract from that. So that's all I'm going to say about this for the meantime. Again, hopefully this article will be out soon. But basically, where the golden star points to is really where we can make good use of some of the tools we have in healthcare education, medical education, health sciences education, and leverage opportunities we have where students experience heightened levels of stress, such as in simulations. And often all you need to do is observe. You don't always need to ask someone how they're feeling. Sometimes you can see it in some of the simulations I've had a chance to observe. I could see sweat forming and on some of the people's backs. And I didn't need a sensor for that. But this can drive home the point that there's something about going and actually actively participating in an activity, which we know from educational psychology literature and educational theory, is a really great way of learning to do something, to be actively involved. And from an emotional point of view, There's a big difference between going from lecture or textbook, or perhaps even cadaveric lab, to something where it's higher fidelity, where there's different aspects of a situation that feel real. The complexity is there. The reactions are there. And this is going to be helpful for giving people a chance to deal with and learn how to deal with that stress. I would argue, though, more that one of the future directions I'd like to move towards will be bringing this more into formal debriefings, so that people can, it's important and helpful for people to be aware of their emotions. Emotional intelligence literature has talked a lot about this in medical education for a while. I'd like to see us move well and truly beyond emotional intelligence to also thinking about not just being aware of emotions and aware of the impact of emotions on our performance, on our ability to think, but also what are some of the things that we can do, and how can we give people a chance to deliberately practice these types of coping strategies in simulation. These are some of the things that I'm interested in moving towards, and having some models is a really helpful starting place. I'm going to move now towards asking you to think differently about emotions, and asking you to think more about them as training tools, basically. And this is, in other words, I'm asking you to think about what are called achievement emotions. And when we're talking about this, we're thinking about emotions as arising in situations relating to meet competency-based standards of quality. This is how achievement emotions are defined. And certainly, competency is a word that's very big right now in medical training and medical education. So it's a nice fit. And why emotions are important in training, above and beyond the value and importance of learning how to regulate our emotions in high stakes situations, is that they can support our motivation. They can help us focus attention and cognitive resources on what we need to do at the moment, which could be learning, practicing, and they can promote situationally appropriate information processing. And they're important in cross context, whether you're sitting down to write an exam or you're in a simulation. They're relevant. And stakes are something that influence emotions. The higher the stakes, the more intense that emotion is going to be. And we know from the literature, the more difficult it's going to be to regulate. When we think about emotions, we can break them down into at least two kind of different categories in terms of something can be pleasant or unpleasant. So on the right hand, we like experiencing emotions like enjoyment. We're not so fond of feeling hopeless, on the other hand. When we think about emotions split differently, so instead of thinking about what's called valence, we can think about what's called activation. This can also be talked about as arousal. So these are emotions that have an excitatory component to them. So enjoyment, anger, these are things that are, while different to experience in terms of pleasant or unpleasant, are activating. Whereas emotions like relief or boredom, these are unarousing. They're unexcitatory. Again, they can be positive or negative to experience. This is an important dichotomy. This has implications for measurement that we're going to talk about. With regards to thinking about how these different quadrants intersect with performance, this is something that's worth considering. So positively valenced, activating, so in other words, excitatory and pleasant to experience emotions like enjoyment, pride, and hope are positively associated with performance outcomes. The opposite is true for those negatively valenced, those unpleasant, non-excitatory emotional states. So boredom, hopelessness, those are not good states to be in if you're trying to perform a task in a simulated or non-simulated procedure, or sitting down to write an exam. Things get more complicated though when we think about the yellow traffic light kind of color, the anger, anxiety, shame, or belief. So we're going to dig a little bit into the anxiety or shame side to illustrate how these can be nuanced. So basically, in the right dosage, anxiety or shame can lead a little bit of that. A little bit of anxiety, for example, can motivate us to try harder. It's like, oh, I'm not sure if I'm going to do well. That wouldn't be good. I better try a little bit harder. This can increase our motivation, and that in turn can improve achievement. On the other hand, if that uncertainty appraisal in terms of thinking about and framing our future orientation leads us to just be like, oh, this is going to be too much, I give up. that can lead us to not be motivated, as you could imagine, and certainly not studying or not preparing. That is not going to lead to positive performance outcomes. These relationships are important to consider as well, because we would imagine that because of the very cognitive nature of emotions, that these would be similar states as well when it comes to actual performance in an operating room. So while I'm asking you to kind of put on your hat and think about these as training emotions, that these are not necessarily, that emotions also have an impact when it comes to performance, and certainly also the performance of others, as we know from research. Some other important assumptions for emotions are that they're what's called multi-componential. So there's different parts to those. So when we often think about emotions, we're aware of a subjective experience. We talk a lot about how we're feeling, but there's also peripheral physiological responses, which we all know. Our heart rate can pick up, and our behavior is something that changes too often with an emotional experience. So if that's facial expressions or posture, those are things that can and do change. When we talk about and describe these as being loosely coupled, the idea is that normally these different components of emotions or emotional expression components would co-occur, or they would align in the ways we would expect. However, because we are complex social beings, we also make efforts often to regulate our emotions, or at least regulate how those emotions appear. And one of the great disconnects between the components of emotions would be between the subjective experience and the behavior. That is something where everyone has had experiences where you might have had to fake a smile. With holidays approaching, maybe we're getting ready to receive pink socks or something like that from a grandparent, and still want to remember to smile or something like that, even if excitement isn't the response. We also know that emotions unfold over time and in response to goal-related events and activities. So this means basically that it's really helpful to, if we're interested in measuring emotions, to get a sense of how someone feels over time. And while self-reports remain the dominant way of looking at and understanding emotions, we can't really get a good sense of how someone felt during an episode of something, especially if it's a few minutes long, because emotions are short-lived and rapidly changing. So someone could have experienced many different emotions over the course, for example, of a simulation session that's often, say 10 minutes in time. And those emotions are going to change in response to some of the events and activities that have happened. So perhaps someone was slow coming to a decision, but you weren't having the role of lead. Maybe you were frustrated initially, but then when they, asked for, what they were supposed to, or things unfolded to the next step, then you were relieved. Perhaps there was some uncertainty as you were contemplating whether you should say something or intervene, etc. We also know that responses are mediated by appraisals. So these are, again, when we reflect on how a situation is relevant to one's goals or not, and whether that situation bodes well or not well for our goals. This could be anything from having a positive patient outcome to just surviving and doing well, or perhaps graduating. So again, there's a range of emotions can be elicited in a range of, or towards a range of different stimuli or potential things. And they're particularly important because of the critical impact that they have on success and failure on a range of outcomes. So as I said, both educational, but also when we even talk about surgical outcomes, emotions can have an impact there. This is still an emerging area of research in medical education, but it's a particularly interesting area from a research point of view. And this is one of the things I was very excited and remain really excited to be doing research in. There are clear opportunities for success and failure in medical training. And there are also things that are really aligned with people's curriculum. So a lot of the research that's done in emotions and educational and social and experimental psychology take place in very removed settings that have what's called very limited ecological validity. So they're not really, they're simulated tasks, but they're not very interesting for students or participants to go through. And this creates a really restricted range of what we would see in emotional responses. And I saw some of this in my doctoral work. which was looking at the responses that students have when they were interacting with intelligent tutoring systems and the virtual agents who populated those systems and tried, with differing degrees of success, to help coach them through learning about the human circulatory system. We've also seen research that's leveraged and used the control value theory, which is one of the theories that my research is drawn on and one of the pillars of an integrated theory that I've published. And so we've seen, again, a number of findings also in surgical simulation. We have a review that's getting close to being out there in the world, and that was presented at the Simulation Summit, the last iteration of it, where we're presenting some of our preliminary results from this, where we were wanting to see what was going on and what had been done with regards to work on emotions and stress in simulation research. We found that there was a real lack of conceptualization or definitions in thinking about emotions. Stress was sometimes viewed as an emotion, sometimes not. We found that negative emotions tended to dominate trainees' experiences, which is not necessarily the case with some other contexts, which was interesting. But there was also a bias for measuring emotions. So if you also only ask students about negative emotions, then they only really have the opportunity to respond about that. And interestingly, to come back to this, stress versus emotion piece, when people tended to talk about stress, they tended to use physiological measures, but there was a heavy reliance on self-report measures when what people were talking about were emotions. This is a bit of there's stress and emotions are for sure things that are closely associated. Stress is sometimes defined really as just the activation dimension of an emotion, but it's often talked about, including in the clinical literature, as being something that falls into, again, a negatively valenced category, which puts it very close to anxiety. So these are some issues also in science and psychology, including clinical psychology, where we have there's some definitional underscoring. But in research, we know that it's especially important to be clear in how we're just conceptualizing and operationalizing our variables. So regardless of what people are doing, all that's important is really that they provide a clear definition of what it is, what that construct is that they're measuring. And we're finding that there's some work to do here. I'm going to show a video that we have developed in my lab. It's actually the first video in a series that we're wrapping up a second phase of data collection on. And it's showcasing the role of emotions. We've been talking about emotions, the need to improve coping with challenging emotions, the role of emotions in training. But there's also something to be said for working with the general public and working with different patient populations to make them aware too of the role that emotions play in their life, and in particular, the way they consume health information. And so I'm just going to play this. This is just a few minutes long.
This is Chad. Chad's at a grocery store, and he's shopping for toilet paper.
I hope this pandemic thing ends soon. Wait, what's this? We're going to have a toilet paper shortage. I hope I'm not too late to stock up.
But Chad sees a sign that says toilet paper is limited to 2 per client.
Only 2? That must be a mistake. I have to stock up after all.
I'm sorry, sir, but toilet paper packs are limited to 2 per client.
Right. But there are more clients at my house. So technically...
I'm sorry, sir, but we mean per household. You'll have to return those toilet paper packs.
But wait, think of the children. We're running out and soon all the stores will run out. Oh my gosh, this cannot be happening right now.
Hold on a sec, Chad. Your emotions are getting in the way of you thinking properly.
Okay, but we're kind of in the middle of a pandemic, right? I mean, you're a scientist or something? Have you seen the news? There won't be enough toilet paper.
Chad, There might be some truth to some people buying too much toilet paper and leaving less for the rest of us. That said, perhaps you're relying too much on how you're feeling right now. And over-reliance on emotions can lead to believing in low-quality information. When we hear about something that we consider helpful or hurtful to us, it can lead to strong emotional reactions, as you're experiencing now. Let's cut out the noise for a moment, and I'll explain more.
Sounds like it would be easier if we didn't have emotions at all.
I wouldn't say that. Experiencing emotions is perfectly natural and part of being human. It is helpful to remember that they can influence how we think and behave. We often do not consider if and how they might be influencing us. Think of emotions like a wave. Now, imagine you are surfing the wave. The bigger the wave, the stronger the pull will be. That's why the intensity of emotions also matter. Strong emotions, or waves, make it difficult to stay balanced.
Wait, do you surf?
Only on space-time.
That sounds like a no. But back to the wave. I guess a tidal wave is bad, but do the emotional waters have to be totally calm? To be honest, even on good days, I don't think I feel like a quiet pond.
That's a good question, Chad. A moderate amount of an emotion, like anxiety, may be helpful in some cases. But too much anxiety is probably bad in most cases, just like waves.
Wait, how can anxiety be helpful?
When you thought there was a toilet paper shortage and you knew you were running low on it, that did motivate you to come to the store, right?
Yeah, you have a point. But you said I overreacted.
Exactly. It wasn't a bad thing that you were motivated to come and get something you needed. But you seemed more than a little anxious just a moment ago.
I guess you're right. But it's hard not to overreact. Everyone is stressed out these days.
It's true that not letting emotions sit in the driver's seat can be hard. But recognizing when they are on the wheel is a first good step. While you shop, I can teach you how to keep a tighter grip on the steering wheel. We can also talk about how to stay sharp, even when the media and information we're consuming might be stirring waves that could become too much to handle.
And we're doing all of that at Walmart?
Yes.
So we're very proud this was an in-house or in-lab production. And I'll just let the scripts play to give credit to my graduate students who played different roles in terms of helping me with the script, playing voices. And again, this was just one of several of the modules for this. We went on to talk about emotion regulation strategies and also media literacy skills that people can use to improve how they think and to recognize the role of emotions in their training. And this was funded by the Social Sciences and Humanities Research Council of Canada. We'll be presenting actually the very first of our papers on that at the American Educational Research Association this spring, which should be fun. But we're really interested in wrapping up the randomized control trial that we're doing at the moment. I think I can see there's a chat question. Oh, I agree, Lucia. Oh, star in the Hall of Fame. Okay, let me see if I can get back to here. Okay, so we've talked a lot about emotions in different ways. There's some other really fun work that we're doing too, before actually I go too far into that, with regards to anti-harassment training. I alluded earlier that one of the things that emotions can do that can have consequences not dealing properly with those emotions is they can spill out into negative interactions with others, and this can exasperate situations or create situations where harassment occurs. And so we have another set of educational interventions we've been working really hard on in my lab during the pandemic. And we are just getting feedback from co-applicants and collaborators on the grant. And then we'll be running our first usability study and creating some simulations around these at the Steinberg Center to use for people to practice bystander interventions. So that'll be a lot of fun too. So emotions are everywhere is the message of the talk. So I'll jump into, again, different assessment methods and some insight that we can get from these. So there's all kinds of different ways of measuring emotions. There's, again, the very basic self-reports that you're probably familiar with. What's important is that those scales or surveys have been validated, or in other words, have validity evidence, as my EXSU 603 knows. And so the physiological sensors are a way of getting at emotional arousal or activation. So they don't provide us inherently, in most cases, with information with regards to valence, whether something is positive or negative, but it depends on the sensor. But it does provide us with that activation information. We can use audio and semantic analysis to get a sense of emotional cues from word choices or prosodic features. So those could be things like the tone or the cadence of the voice. We can use video and machine learning to get a reading of posture. Connect has been around for a long time, and I think that it was less successful in being integrated into the video game market than it was being used in some work in affective computing, which is an area of research looking at different emotion measurement modalities to capture emotions. But there was some interesting work that was done there, getting a sense of and associating things like leaning forward or backward, for example, with emotions. There's also, this is the connection with regards to artificial intelligence. Facial recognition software draws on, as you probably know, artificial intelligence. The facial recognition software that we work with my lab draws on two different types. One is an active neural network or an active appearance model, what they call, to map, so to take a face basically, and then to map many different what are called action units in the, according to Ekman and Friesen's work with regards to emotional expressions or universal emotional expressions. And then once that face has been mapped, then it imposes a series of artificial neural networks, which is a different type of AI that have been associated with different emotions, such as surprise or fear or anger. And it provides a goodness of fit index to give a sense like this does here. So this person, I think, is supposed to be sad. This can be used for getting a sense of how someone's feeling. I'll be interested to see whether or not we can use this at all in some of our simulation work research, but we're certainly going to be able to use it with regards to the research we're doing that's more lab-based, where we're, for example, piloting some of these educational interventions, which are in some cases the first step to a more complete educational intervention, which includes simulation training, as is the case with our anti-harassment project. We can also look at other kinds of psychological measures for emotion relevant or emotion adjacent clues, such as, using eye tracking to get a sense of attention, for example. Attention is important because, as we talked about before, emotions can arise from all kinds of different things, or more specifically, our appraisal of how something is good or bad in relation to a goal we have. So by knowing what someone's looking at, this provides us with valuable information in terms of where that feeling might be coming from. It's important to look at, ideally speaking, a range of different data channels to look at measuring emotions, because they can tell us different things. So as we're seeing from this, emoticon representation of faces versus self-report measures, and then again, this curve down here is an example of a physiological activation. This would be more skin conductance level rather than response, which we'll talk about in a moment. We can see that we're not really getting a lot of variation with regards to the faces when it comes to looking at neutral or bored. This is not necessarily what bored looks like. It would be more helpful if people were always so clear. From my experience, facial expressions are best at getting at more intense emotions. And boredom is not one of the basic emotions, largely because it seems to be something that's more subtle. And so this can be difficult to capture with emotions. Similarly, positively valenced emotions, curious and happy, are different emotional experiences. However, again, what they'll look like facially, can be fairly similar in a lot of cases. That being said, with enough data, we might be able to get somewhere different with regards to advances with facial recognition software for the purposes of emotional detection. So as I mentioned, multimodal, that's what it's called. And multimodal is a word that is very popular in research. It just basically mean there's multiple modalities. When we're thinking about this in terms of emotions, we're talking often about bringing together different components. So multi-component kind of emotion measurement would be probably a better term, but multimodal has been popularized for the last a little while, so it's probably too late to try to change the course of that ship. But as we said, it can be hard to tell some things apart. We also don't see everything. So we would, without capturing data from sensors, we wouldn't have an idea on someone's excitatory response. And while it's easier to regulate, whether we're smiling or whether we're leaning forward or backwards, for example, our behaviors, it is a totally different thing to try and regulate one's physiological responses. That might be more something that would happen in a James Bond film, which would be quite interesting to see someone, try to do that and have that kind of research angle in one of the movies. It's also a problem to interrupt people with self-reports in the middle of a simulation. That can pose problems and really just throw the educational value out the door. So by bringing these different measures together, we can overcome measurement challenges, and we can also avoid damaging the educational integrity of a simulation or other type of educational activity we're doing. So we can look at external validity from these different measures by looking at how they're associated in ways we would anticipate, and we can improve our temporal granularity. One of the most influential studies I've done, probably has the most publications, I think around 150 at this point in time, I did work in my doctoral degree bringing these three different measures together. I'll just go through this very quickly because it provides a little bit of an example of what this can look like. So we asked people to fill out a single item self-report measure for discrete emotions. I won't go through all of these. So for example, we also gave people a definition to describe, to make sure people knew what we were talking about with regards to the emotions. This was one of the first high impact factor publications of what's called experience sampling in psychology. So people have really moved away from some of the extra precautions that we took, like definitions and et cetera, and are moving towards other things. So we first published that in 2013, and then in a conference proceeding for artificial intelligence education, then later in 2015 in computers and human behavior. There's been some other self-report measures that have come since that also are interesting. And we used Face Reader and we continue to use Face Reader. I think we're on Face Reader 8. So this is actually a picture of Face Reader 5. I need to change the slide and update it. Now that we'll have, as soon as the cameras come in the mail, I know that there's some lab members in the audience. We'll note to self, we'll have to take a new picture of this and update this, but we're on Face Reader 8. So these are the different artificial intelligence networks I was talking about. This software has been validated, obviously, with previous research before being used. Whenever you're looking at emotions across different modalities, an important thing you have to do is you have to align them. And that means you have to you boil them down in some cases into higher order categories. So we talked about activation. Activation is typically grouped into high and low, as you saw, valence, high and low. But the emotions can also be grouped together according to these different valences. We often do distinguish anxiety and frustration, or in other words, fear and anger, just because of how different these experiences are. And from an educational point of view, these would likely call for different reactions. What we found in this work was that the self-reported experiences and the experiences we got from our automatic facial recognition software were quite closely correlated relative to what we would expect, theoretically. So 75 agreement was pretty good as a correlation. But if we look with regards to the what was a Q sensor, and we're using a different physiological sensor now, the agreement wasn't so good. The reason we believe this was largely the case was that there was so little variability in people's physiological reactions because, to put it bluntly, they didn't really have a reason to care about their performance in this particular task. And because of that, we weren't really able to do much in the way of observe the physiological responses. So as I noted before, this is one of the reasons that conducting research in much more ecologically valid contexts, such as in simulations, is really exciting because we can look at people's emotions in a much more emotionally intense environment, and one where students are much more emotionally invested also in terms of doing well. They can imagine how this would translate to patient outcomes, and they can also want to be able to do well and master the task because it's something that's related to what their career goals are. We've done some work recently when we were able to collect skin conductance data before the pandemic, recently looking at what's called tonic versus basic electrodermal activity. Tonic EDA is smooth or underlying slowly changing levels. These are referred to as skin conductance levels. These need to be, standardized because people have different baselines, or people have different levels of these, and their baselines can move. Phasic EDA refer to rapidly changing peaks in electrodermal activation. These are associated with short-term events. They're referred to as skin conductance responses. They can arise in relation to specific events we can look at measuring and outside of those. Of the two, these are the more interesting ones because we can, first of all, get a sense of whether someone's in a higher or lower activating sense from getting a sense of how often these peaks are happening. But it can also be interesting for us and educationally valid or valuable to look at when are these peaks happening and use these perhaps in a future context as part of debriefing to zone in on something we might want to discuss or focus on, or use a moment in a simulation where perhaps things stopped, things didn't go well. Or use, if we have kind of a video replay opportunity and can visualize the data, which we can do, although we would need to develop a dashboard, would be to showcase how when some critical event happened in a simulation, this also corresponded to people's skin conductance levels fluctuating. Skin conductance has, like facial recognition software, evolved tremendously over the years. We started out with something that looks like it came out of a Happy Meal, which I've published a good amount with. There's other devices like BioPack, which are good industry standard things. However, the electrodes are a pain from my experience. If people are sweating too much, the electrodes can fall off, or if people are just moving their hands too much. And what we've been using most recently, and one of my students, Lucia, conducted a great review as part of her non-thesis project with my lab, looking at what would be, given what's out there on the market right now for physiological sensors, outside of what happens with our electrical engineering colleagues, where you can just kind of build your own. What is kind of the best thing on the market? And the Empaticas seem to still be the best thing on the market in terms of something that has lots of different affordances. And they're easy to use. And I didn't put up a disclosure thing. I'm not paid by Empatica. This is just what I'm using. So if anyone is interested in these sorts of things, this is what we're continuing to use in the lab. I use them at my previous lab at the University of Alberta as well. And they've got a lot of nice features, like being able to note when a simulation is started and stopped with event markers. There's a real-time streaming, and there's some also controls built in to try to identify when there's a lot of motion going on. So we found these to be nice. This is what some of the data looks like when it's being acquired in progress, although of course we export these to CSV or Excel files. Some of our research looking at skin conductance and emotions has found that habitual suppression strategies, which are in the literature the least likely to be associated with successes at regulating emotion, positively predicted medical students' skin conductance levels. And there was a positive predictive relationship between skin conductance and shame and anxiety. Both of those make sense theoretically. And we found that skin conductance responses positively predicted diagnostic efficiency. So in this case, we hypothesized that those students who are experiencing more physiological activation were probably more invested in the task. I think I'm looking at the time. I think I'm going to end close around here. Something that we're looking at right now and have under review with IRB is to look at what's called physiological synchrony. And so we've often looked at in research in psychology people's individual physiological responses. This is what's typically done, and so people might be interacting with with a technology, or they might just be reading something or whatever, and we're looking at what they're responding to. It would be possible to look at how multiple people are responding to something externally driven and whether there's similar responses. It doesn't really matter this doesn't have to be synchronous though, in the sense that people could be reacting the same way whether they're sitting all at the same time or not. And unless there's verbal or social cues that might not be meaningful. There's other kinds of patterns, but what we're really interested is moving towards heavy metal or that's at least the illustration with regards to group interaction, because we know that emotional contagion is a thing. In other words, we're social creatures and emotions are such an important part of how we are social. We read and rely on emotional cues a lot in our interactions with people to gauge people's interest, acceptance, whether they're irritated by something we're saying. And these things, we've been learning to deal without these things during the pandemic. And it's been hard, I'm sure, for a lot of people. It's certainly been more difficult to me. Right now, there's zero social information because I don't see anyone's face. So there's some irony to talking about that, not in a lecture hall, but on a single monitor. We're interested in bringing these dynamics into medical training, simulation training, and also into the operating room. With the help of the injury repair recoveries or the RI-MUHC's experimental operating room, which we'll be using. We've purchased 8 of these physiological sensors so that we'll be able to accommodate teams, often 4 or 5 people. And we're interested in looking at associating the events that happen and the physiological responses and trying to get a sense of, whether or not we're seeing synchrony in how people are responding. And this is what we're roughly expecting, but we think that this will be really valuable information to have to help us to better understand how groups, how people not only individually regulate their own emotions, but how we can better support and provide better training for the regulation of emotions in teams. So in other words, individual, but also, or intrinsic, but also extrinsic emotion regulation, which is much more complex. And frankly, even individual emotion regulation is only something we've just started looking at in the broader educational psychology literature. So this is very exciting, and we think will be really helpful. There's a lot of different, technologies with different types of affordances that heighten, as we were talking about before, emotional activation, and these can be particularly interesting environments to look at emotions in. One of the environments we're looking at that in is Oxford Medical Simulations work. We've done some research. We're doing work with both physicians, but we're also with nursing students. This has been interesting stuff. I think I'm going to probably wrap up there though, because it's been nearly an hour since I've been talking, which is quite a while. So I'll just kind of zoom through some of these things. If people want to talk about theories later, I would be happy to. I'll stop there. Thank you for coming, signing in virtually, and I'd be really happy to take questions if there's any.
Thanks, Jason. That was great. I was wondering whether Elaine had a question there, but I think she was just saying that it was, she also enjoyed it. Maybe I can ask you some low-level questions. Oh yeah, so people have got their hands up, I see. Dr. Fried.
So Jason, thank you very much. That was an amazing talk, and there's so much in there that I'd love to pursue. But my question really is about cognitive overload and emotions. So we know that certainly in surgery that the more a person is doing something that is unique, that maybe they're challenged to sorry.
It's okay.
Okay, can you use any of your analytics for emotional stress, et cetera, to be able to determine whether a person is being cognitively overloaded? Because I think it's a very important issue when we train people in technical skills so that they have enough reserve to be able to make appropriate decisions during surgery.
That's a great question, Dr. Fried. And I love that in a way your phone ringing and you asking about cognitive load was really appropriate, because that was a great example of extrinsic cognitive load going on as you were trying to get the question out. So that was a great question. I think that I could talk probably a lot about that, but I think what I'm going to say is that what's interesting is that emotions can also contribute to cognitive load. And so we would expect that if people are experiencing high levels, particularly of a distracting emotional, of distracting emotion, that's going to contribute to cognitive load. It's going to contribute specifically, I would imagine, to extrinsic cognitive load. So that's something that we would probably expect an association between those two. Probably also because cognitive load, things become more difficult as we become more overloaded, and we're aware, we're cognizant of that. And so that can make us more anxious or uncomfortable. But we're actually in our work right now with Oxford Medical Simulation. Our next phase with that, we're looking at cognitive load directly. And so we're going to be looking at the relationship in some different ways to cognitive load, and hopefully getting some people into the lab so that we can observe these relationships more dynamically. So happy to talk to you a little bit more about that later, but hope that short answer works from now, as I think there's at least one other question.
So,
Thank you.
yeah, I'm going to abuse my role of host to kind of steal Ovi's slot for a second. But I just want to ask you about, you talk about giving people, the means to sort of control emotion and be more effective during learning. Do you think then that that's just a temporary thing that people do to get through assessment, and when they go into their practice, they continue to use those things, or whether do you think their real character kind of comes back again, and they start to do, be more emotionally controlled than they pretended to have been during learning?
That's a great question, Dr. Bartlett. And there's kind of a few different dimensions to it. I think that one of the dimensions to it would be how we would assess the effectiveness of these sorts of interventions. And to be honest, we're at the point right now where we're building up, we're kind of taking stock of the situation itself so that we can gather the materials, gather the scientific background, and leverage that evidence with the theory so that we can move towards building some kind of intervention, which is one of the end goals, actually, of one of my current SSHRC grants.
Sorry to interrupt you then, but the faculty spend a lot of time and money on trying to select appropriate people from a pool of overachieving academic high flyers to become doctors, right? And do you think ultimately it's sort of their emotional maturity or intelligence or whatever that is really determining suitability, and maybe should some kind of assessment be made at selection rather than trying to improve people during training?
Okay.
Not many people leave training once they get to a certain level. That's what I'm trying to say.
I get it. Thanks for clarifying your question. That's also a good question. I think that, to be honest, I don't think we're there yet with regards to the field of affective computing, which is really a combo of people in different areas of psychology and computer science. We're still working on advancing the accuracy of our different tools. And that's kind of part of that is, advances in engineering, part of it is advances in analysis, part of it is advances in theory. And then of course, there's more research. So I know that's kind of a bit of an unsatisfying answer, but as a fellow scientist, the answer being we need more research and we need more research funding will at least not be alien. I think that part of that is also that this is a relatively young field. And it's a very interdisciplinary one. In terms of whether, to answer kind of the other part of your question, so we're not there yet. Could we be there? Could we go there? And should we go there? I think that's a different question. And there's a lot of, you have to be at a place where your measurements are extremely accurate and extremely reliable in order to make high stakes decisions. Where affective computing is good, I would say right now, would be at helping us to better understand why, what works well and what's not working well, identifying risks, et cetera, in an environment. But to be taking information from a relatively, a kind of a tiny cross-sectional piece and trying to make inferences from it would be really tricky. So that's, we would also need, there's also some technology that's just not there yet. So for example, facial recognition software needs to come a ways further. So it needs to be able to equally and effectively classify everyone's faces before something like that could be used. And so it's not there yet either.
I'll take that as your answer. Thank you very much. I know it's complicated. Sorry, video, you've been very patient there. Go on.
Yes, hi. Thank you very much. It was very interesting to see that there is work done in this domain. I have an interesting puzzle here. It's about, I assume you're using the Vicar Vision software, and that one, it's notoriously known that it's used to measure and quantify engagement, and all of those criteria, not only in like in face of a camera, but even during a webinar. So are you analyzing? You can use us as a good sample group. That would be interesting. But also they have they can do also in-depth behavior analysis from walking patterns to kind of like knowing how much and how long I'm looking at someone like that. And I think it will be interesting also to kind of introduce that as a multimodal thing in looking at the emotion reaction analysis. And but this will raises the obvious question about the ethics of using it. How do you see the hurdles of this brilliant type of simulation that you can do it in a controlled environment versus the implementation hurdles in a space that is notorious for being very reluctant to kind of being open to their own emotions? They even deny them. I know that because I was there.
Can you give us a short comment on the ethics then?
Yeah, no, I thought that was a good question. And I think that also relates a little bit to where are we in terms of, this field? I've actually found that people have been, so my research is very much about surgical education and healthcare education. And from speaking with so far a number of simulation educators, people have been really interested in my team and I coming in to work with them. And the reason for that is that our objective is to use these different measures as well as others that we've developed to improve simulation training, especially simulation debriefing. And so how can we, for example, as we know, reactions is often how we start talking about a debriefing, how did everyone feel, et cetera. And so if we can identify using these tools, disparities or differences in how people were feeling or when they had those feelings, those could potentially be interesting those could potentially be interesting data points for simulation educators to have. It can also help improve the awareness of trainees with regards to the role that their emotions can play in performance, which can help remind them that it can be not only helpful, but maybe, but critical to be mindful, of, say, rising anxiety or rising frustration, and being mindful to deploy, an adaptive strategy, before they get to a boiling point. Or something toward that end. What I would really like to do with especially the sensors would be to develop some kind of a dashboard that we could allow simulation educators to use to summarize the emotional information that residents, students, others are experiencing during a simulation as part of the other really interesting tools that they're working with during a simulation. And that kind of, privileged viewpoint could be shared with the trainees to give them a snapshot or an overview of how they were feeling, during a simulation itself. And we know that this is really important for communication and collaboration, which are, critical, which are core competencies in medical training. So these would be great starting points, or other pieces to build into a conversation and a constructive conversation about these non-technical skills. So I hope that answers your question.
Yes, thank you very much, and impressive and really nice work of a piece of software that it's usually used for other stuff to be put into a good service. Thank you very much for what
Thank you
you're doing.
Thanks, Vidya. Dr. Wiley, you have a controversial question.
Jason, wonderful. Really enjoyed it. So I'm just questioning the premise. Two premises. One premise that is for stress, and the other one for emotion. So, what do you think about those who say that stress is good for you?
I would say that I would say that it depends on the quantity. So there's a law in emotional research called the Yerkes-Dodson's law. And the idea here is that a little bit of stress or a little bit of anxiety can be a good thing. It can motivate people. And so this is part of where we need to have nuanced discussions about emotion, because there's a difference between an environment being emotionally safe and between an environment being emotionally sterile, or in other words, emotionally stressless. In a simulation setting, it doesn't serve, or it doesn't serve students as well as it would if there was an opportunity to experience some stress, because they're going to be experiencing some stress when they get out there in the operating room, when they're interacting with patients. And so that's really part of the idea. So for the people who are saying that stress is good, I would say absolutely. But it also, you also don't want to impose necessarily too much, or to recognize when, there can be, and this is a debate in simulation communities as well, there usually are stopping points. So if someone is just completely overwhelmed and floundering, you don't necessarily need to drag something out. You can recognize that it might be fair to just put things on pause and talk about, what worked and then what didn't work. Does that answer your question, Dr. Molly?
Yes, it does. And about emotions, from when you developing the devices, it's really wonderful. So your premise is that emotions are hardwired, and they are, is that the premise, and that they are reflexive?
I guess I would ask you what you mean by hardwired exactly.
Hardwired in the sense that we all have this fingerprint on our brain, and if something happens, that we are going to respond in a very automatic way. So because when you're doing the programming, you're developing the program, it will be basically Faxon smiled, he's happy. So is it hardwired in the brain, maybe evolutionarily hardwired? So is that the premise? Is it based on things being hardwired and then it's expressed that way?
That's a really good question, Dr. Mwale. Emotion, I would say it's a little bit more complicated than that. There is, I think some of the arguments you're bringing forward are evolutionary psychology arguments, which are good, and they're absolutely part of it. But that's where appraisals come in. And so it's a little bit like that metaphor, if a tree falls in a forest and no one hears it, did it matter, or something like that? I'm terrible with analogies. So with emotions, it's a little bit like that too. So, let's say there's a tree that falls. You have to have seen it in order for, first of all, this to be on your radar, right? For it to be for it to go through the appraisal system. But it going through the appraisal system, which is a cognitive component of emotions, this is what's going to determine what the emotional response is. So if, for example, the tree falls and it was in your backyard and it's just fallen towards your house, that's probably not going to be a positive emotional response that's elicited, unless you were chopping down that tree to bring your house down or something. Maybe you had an insurance scheme going on. On the other hand, if you were chopping down the tree for the holidays, for example, maybe it was hard work or whatever, and the tree finally fell, you could have a very different emotional response because of your objective in relationship to that tree. So there are emotions themselves are things that are biologically routed in the sense that, we especially with, the physiological, the other pieces, but there's also a lot of pieces that intersect with the cognitive. So those can be social and cultural as well. So whether something is good or bad can be influenced by those different elements as well. So does that help? I nearly put the slides back up because the model of emotion regulation that I've published, Jake was shaking his head, don't put the slides back up. We go over that and talk about, what are the dimensions in an educational situation that really inform how emotions arise, and based on at what point those emotions arise or the directions that those emotions arise from, what are the strategies that are going to be most effective at regulating those emotions? But I won't go back as Dr. Bartlett has requested with his nonverbal behavior to the slides, and I'll leave it there. So hopefully that helps answer your question a little bit, Dr. Molly.
Yeah, that's brilliant. Thank you very much, Jason.
Complicated, Dr. Wiley. Far more complicated than that. So, but I think it's interesting. I mean, we're basic scientists, and I think goes to show that the context is very important. I'd just like to get the reason I'm pushing on. I'd like to get to a question from Sarah, who says, what do you think about the temporal sequence between emotions and daily behavior, physical activity levels, sedentary sleep, eating, I presume, and the daily variability of these variables between person and within person levels? I think generally that question is about variability, and can you detect things then if things vary a lot?
Well, this, especially when we're dealing with physiological data, we need to be aware of individual baselines. First of all, in some cases, some people can be what are called hypo-responders, where they just, as the name suggests, they're just not very responsive. And they can be hard to collect that kind of data from. It can also be important to get, especially with physiological data, information like, did people have caffeine, before I connected them to a particular device, because that can create artifacts in your data. And so these are important things to get. I say though that in terms of, so while there is also, and we know that there is individual variability, emotions are not the same thing as moods. And so moods are more kind of like longer lasting. They're not targeted towards something in particular. So even though some people might be more emotionally reactive than others, it's still of value to get a sense of how people are emotionally reacting and what they're emotionally reacting to. From an educational point of view, the objective of doing this is so that we can make sure that the environment that they're learning in is going to be as supportive to learning as possible. And in some cases, as per one of the earlier questions, that means calibrating the level of stress so that there's a little bit of it, for example, but not so much that someone's going to be just paralyzed. There's probably a lot more that I could say on that one, but I think that's probably a good level of detail to pause on. What do you think, Dr. Bartlett?
I understood the answer, so I think that's a good baseline. A good metric of successful answering. I just want to ask you a couple of things one is about COVID burnout. Obviously, some people are burning out because they're just overworked and under-supported. Then there's people like me that are not clinicians who somehow felt burnt out just by being stuck at home. And I wanted to ask you there, clearly it's not being overloaded, but is it is it this sort of endless uncertainty that, in the back of your mind, you're kind of worrying about stuff, or is it, why do people who are not kind of physically or, time-wise overworked, why are they burning out?
Yeah, I nearly wanted to go back to my media notes because I talked about that a lot like a year ago. I would say that, one of the pieces of that is that, we're not used to experiencing, emotions, as we were talking about before, something that are, they're rapidly changing. They're in relation to a particular, event. But COVID has been such a profound event that's lasted such a long time. So it's something that has elicited emotions over, hour by hour, day by day, week by week, for an increment that's now in years. And I think many of us, no matter how old we are, haven't lived through an event that has been, overarching enough to have had an impact, and a negative impact, on our daily life, and on our, and this has in turn, this elicits, again, undesirable emotions, and these emotions are tiring to experience. There's also a concept, I'm going to go back into the early days of psychology, a Freudian concept. Freud had lots of ridiculous concepts. They were fun, but we won't talk about the merit necessarily from a replicable or validity point of view. But one of those was psychic energy, which sounds very paranormal psychology. But the idea was that we only have have limited reservoirs of psychological energy. So a little bit like not quite the same thing as cognitive load, but our attention is kind of limited. And so our emotional energy is also somewhat limited. And I love the analogy in video games, if anyone plays video games, where if your character has a curse or something on them, you've got your health bar, let's say it's like this, during that period of time, you won't be dealing with a full health bar. You'll be constantly dealing with something like this that's shortened. And that's a little bit what it's been like for people, I think, to go through COVID to varying degrees, where no one really has their full health bar because this looming, constant thing that has implications in our professional lives, in our personal lives, has been there, and it's difficult to ignore. And from an emotional point of view, again, if you can't ignore something, it's going to continue to elicit emotions. And so that's part of why people, even for those of us who are not clinicians, have been struggling in different ways and to different extents, because it's tiring to experience that quantity or volume and duration of emotions like anxiety and fear, etc. And that's gonna be my not so short answer, but
maybe this could be a yes/no answer for you. You mentioned one of the most beneficial strategies for dealing with this was, I think you called it adaptive reframing. Is that basically saying, well, it could be worse, and then thinking that it's not so bad because it's not worse?
That is an example. There's a lot of different ways of engaging in reappraisal in educational context. One of them is control, one of them is value. And I guess saying that it could be worse, would definitely fall under that camp. One of the things that I encourage people to do, during some of the talks to media and different medical associations and stuff, was for people to remember to focus not only on the things they don't have control over, but to try to remember and identify things that they do have control over, and to try to, to find ways of exercising that control and in a positive way. And similarly, with regards to, thinking about, what we call appraisals of value, so how important something is, this is a little bit like what you're talking about, Jake, the it could be worse. That's good to remember. And I encourage people to think about basically, that, how good or bad something is on a scale, that something isn't just, wonderful or a disaster. but that there's, there's gradients to that. And sometimes that nuance can help people to go from catastrophizing something to putting a little bit more effort into situating it on a little bit of a more well thought out scale.
Great advice. Dr. Harley, thank you so much. We have really enjoyed your talk and your discussions.
My pleasure. Thank you very much for moderating, and thank you everyone for wonderful questions. Really enjoyed those.
Great, thank you.